Let me begin by challenging a belief many of us have carried for years, the idea that more medical testing automatically means better health. It sounds logical, doesn't it? The earlier we detect a problem, the sooner we treat it, and the better the outcome. But as we grow older, especially beyond the age of 60, that belief deserves a closer, more careful look. You see, the goal of medicine is not simply to find more conditions. The goal is to help people live longer, yes, but more importantly, to live better. And sometimes, these two goals are not served by doing more tests. In fact, there are situations where additional screening can lead us down a path that offers little real benefit, and, in some cases, causes more harm than good. Think about this for a moment. As the body ages, it naturally undergoes changes. Not every abnormality that shows up on a test is dangerous. Some are slow, growing, harmless, or unlikely to ever affect a person's quality of life. Yet once something is discovered, it becomes very difficult to ignore. It sets off a chain reaction: more tests, more appointments, more procedures. And before we know it, we are treating something that may never have needed treatment in the first place. This is what we call overdiagnosis. It is not a failure of technology. In fact, it is a consequence of how advanced our technology has become. We are now so good at detecting tiny changes in the body that we often find things that would have remained silent for the rest of a person's life. But the moment they are found, they are labeled as problems, and that label can change everything. Now, imagine the emotional toll. A test result comes back abnormal. Even if it turns out to be nothing serious, the days or weeks of waiting, the anxiety, the sleepless nights, those are very real costs. And they are often overlooked when we talk about the benefits of screening. Then there are the physical risks. Many screening tests do not end with the test itself. They lead to follow-up procedures, biopsies, imaging scans, sometimes even surgeries. For a younger person, the body may recover quickly. But after 60, the risks associated with these interventions increase. Healing takes longer. Complications are more likely. What started as a routine screening can evolve into a series of medical events that affect a person's independence and overall well-being. We must also consider a very important question. Will this test actually change the course of my life? Because if a screening does not lead to a treatment that improves either the length or the quality of life, then its value becomes questionable. It is not enough to detect a condition. We must ask whether acting on that detection truly benefits the patient. This is where the concept of meaningful care comes in. At this stage of life, healthcare decisions should be guided not just by what is possible, but by what is purposeful. We have to move away from a one-size-fits-all approach and begin to think more deeply about what each individual truly needs. Some people are in excellent health at 60, 70, even 80. For them, certain screenings may still make sense. Others may be managing chronic conditions or facing limitations that make aggressive testing and treatment less beneficial. And that is perfectly okay. The goal is not to do everything. The goal is to do what matters. I often encourage patients to reflect on their priorities. What does good health mean to you? Is it about extending life at all costs, or is it about maintaining comfort, independence, and peace of mind? These are deeply personal questions, and the answers should guide the decisions we make about screening, because at the end of the day, more testing is not always better care. Better care is thoughtful, individualized, and focused on outcomes that truly matter to the person sitting in front of us. And sometimes, the wisest decision in medicine is knowing when not to test. Now, building on that idea, we must look more closely at something that is often left out of the conversation: hidden harms of over-screening. Because while screenings are usually presented as simple, routine, and harmless, the reality is far more complex, especially after the age of 60. When people hear the word screening, they often imagine reassurance, early answers, and peace of mind. But what is rarely discussed is how frequently these tests can lead to uncertainty instead of clarity. One of the most common outcomes is what we call a false positive, a result that suggests there is a problem when, in fact, there isn't. And that single moment, when a patient is told something might be wrong, can set off a cascade that is difficult to stop. Consider the emotional impact first. A false alarm is not a small thing. It introduces fear, stress, and a sense of vulnerability. People begin to imagine worst-case scenarios, sleep is disrupted, daily life becomes overshadowed by worry. Even when follow-up tests eventually show that everything is normal, the emotional residue can linger far longer than we expect. That kind of stress is not harmless. It affects the heart, the mind, and overall well-being. But it does not end there. A false positive rarely stands alone. It is usually followed by more tests, often more invasive ones. A simple scan may lead to a biopsy. A routine check may lead to a procedure that carries its own risks. And with each step, the stakes become higher. After 60, the body does not respond the same way it once did. Procedures that might be considered low risk in younger individuals can become significantly more taxing. Recovery takes longer, complications are more likely, and in some cases, the intervention itself can cause more harm than the condition we were initially searching for. There is also the issue of incidental findings, unexpected results that are unrelated to the original purpose of the test. Modern medicine is incredibly good at uncovering these small, often insignificant abnormalities. But once they are found, they are very difficult to ignore. They demand attention, follow-up, and sometimes treatment. And yet, many of these findings would never have caused symptoms or affected a person's life if they had remained undiscovered. This is where the line between benefit and harm becomes blurred. We begin with the intention of protecting health, but we may end up creating a cycle of medical intervention that offers little real advantage. It becomes a process driven more by possibility than by necessity. Another important factor to consider is overtreatment. When a screening detects a condition, especially one that is slow, growing, or unlikely to progress, it can lead to treatments that may not be needed. These treatments can carry significant side effects. They can affect mobility, independence, and quality of life. And for many older adults, preserving quality of life is just as important, if not more important, than extending it. We must ask ourselves a very honest question. If a condition is unlikely to cause harm during a person's natural lifespan, is it always wise to treat it aggressively? The answer is not always yes. In some cases, careful monitoring or even doing nothing at all may be the better option. But that choice requires awareness, confidence, and a willingness to step away from the instinct to act immediately. There is also a financial and practical burden that often goes unspoken. More tests mean more appointments, more travel, more time spent in medical settings. For many individuals over 60, this can become exhausting. It takes time away from family, from daily routines, from the simple joys of life. Healthcare should support living, not overshadow it. What makes this issue particularly challenging is that overscreening often comes from a place of good intention. Patients want to be proactive. Doctors want to be thorough. No one wants to miss something important. But in trying to avoid one risk, we may unintentionally create several others. This is why balance is so essential. Screening should not be automatic. It should be intentional. Each test should have a clear purpose, a meaningful benefit, and a reasonable expectation that it will improve outcomes that matter to the patient. Without that clarity, we risk turning healthcare into a cycle of unnecessary intervention. And so, as we continue this conversation, I want you to remember this. Every test carries not just the possibility of answers, but also the possibility of consequences. And understanding those consequences is just as important as understanding the test itself. Because sometimes, the greatest harm in medicine does not come from what we miss, but from what we find and choose to pursue without question. As we move forward, it becomes clear that one of the most important shifts we must make is in how we define appropriateness in medical care. For a long time, age has been used as a primary guide in deciding who should be screened, when, and how often. And while age does provide useful general direction, it is far from the full picture. Because the truth is, two people at the same age can have completely different health realities. At 60 or beyond, health is no longer a simple number. It is a combination of physical strength, mental clarity, chronic conditions, lifestyle, and overall resilience. Some individuals remain active, independent, and free of major illness well into their later years. Others may be managing multiple health challenges that affect their daily lives. Yet too often, screening decisions are made based on age alone, without fully considering these critical differences. This is where we must begin to think more personally, more carefully, and more respectfully about each individual. Because what benefits one person may not benefit another, and in some cases, it may even cause harm. Imagine two individuals, both 70 years old. One is physically active, socially engaged, and managing no significant health issues. The other may be living with heart disease, diabetes, or reduced mobility. If both are offered the same screening tests without distinction, we are ignoring the context that truly matters. The first individual may still benefit from certain screenings that could meaningfully extend or improve life. The second individual, however, may face greater risks from the screening process itself than from the condition we are trying to detect. And this brings us to a crucial concept: life expectancy and functional health. Not in a cold or impersonal way, but in a practical, compassionate sense. We must ask, is this screening likely to provide a benefit within the time frame of this person's life? Because many screenings are designed to detect conditions that take years, sometimes decades, to become harmful. If a person is unlikely to experience the effects of that condition within their natural lifespan, then the value of detecting it early becomes much less clear. This is not about denying care. It is about aligning care with reality. It is about ensuring that every decision we make has a purpose that is relevant to the individual in front of us. Another important factor is the burden of existing health conditions. Many older adults are already managing multiple diagnoses. They may be taking several medications, attending regular appointments, and navigating the challenges that come with chronic illness. Adding more screenings into this mix can complicate care further. It can introduce new variables, new risks, and new demands on both the body and the mind. We must also consider how these additional interventions might interact with existing conditions. A test that seems straightforward on its own may become more complex when layered onto an already delicate health situation. The body's ability to tolerate stress, recover from procedures, or adapt to treatment is not the same as it once was, and that must be taken into account. Beyond the physical aspects, there is also the question of personal values. Health is not just about clinical outcomes. It is about how a person experiences their life. Some individuals may prioritize longevity, willing to undergo multiple tests and treatments in pursuit of more time. Others may prioritize comfort, independence, and freedom from medical intervention. Neither perspective is right or wrong, but both deserve to be respected. This is why individualized care is so essential. It allows space for these preferences to be heard and honored. It shifts the focus from what is typically done to what is right for this person. And that shift can make all the difference. It also requires a different kind of conversation, one that goes beyond checklists and guidelines. It involves asking deeper questions, listening more closely, and being willing to tailor decisions based on what truly matters to the patient. It is not always the fastest approach, but it is the most meaningful. In many ways, this is where medicine becomes both a science and an art. The science provides us with data, probabilities, and general recommendations. But the art lies in applying that knowledge in a way that fits the unique circumstances of each individual. It is in recognizing that guidelines are tools, not rules, and that true care requires flexibility, judgment, and empathy. So as we think about screening after 60, we must move away from automatic decisions and toward thoughtful ones. We must consider the whole person, their health, their history, their priorities, and their future. Only then can we make choices that truly serve their well-being. Because in the end, the best care is not the care that does the most. It is the care that fits the person. If there is one principle that can bring clarity to all of this, it is this. The best medical decisions are rarely made in isolation. They are made through conversation, through understanding, and through shared thinking between the patient and the clinician. And after the age of 60, this becomes even more important because the stakes are different. The priorities are more personal, and the outcomes we value are no longer just about numbers on a report. Too often in healthcare, decisions about screening are presented as automatic steps, something that should be done because of age or routine or protocol. But medicine, at its best, is not mechanical. It is not a checklist we run through without reflection. It is a dialogue, and in that dialogue lies the opportunity to make choices that truly reflect what matters to the person sitting in front of us. I often encourage patients to feel empowered in these conversations, because silence in the consultation room can sometimes lead to decisions that are not fully aligned with their values. It is easy to assume that the doctor always knows best, or that every recommended test must be necessary. But in reality, good medicine welcomes questions. In fact, it depends on them. Questions like, what exactly are we looking for? How likely is it that this condition will actually affect me? If the result is positive, what would we do next? And perhaps most importantly, if I choose not to do this test, what are the realistic consequences? These are not signs of doubt or resistance. They are signs of engagement. They reflect a patient who is participating actively in their own care. And when these questions are asked honestly, something very important happens. The conversation shifts from routine to relevance. It becomes less about what is generally recommended and more about what is specifically appropriate. That is where meaningful care begins to take shape. But for this to work, there must also be honesty from the clinician's side. We must be willing to explain not only the potential benefits of a screening, but also its limitations. We must be transparent about uncertainty, about probabilities, and about the fact that not every detected abnormality leads to better outcomes. This level of openness builds trust, and trust is the foundation of every good medical decision. In many cases, when patients fully understand both sides of the equation, the possible benefit and the possible harm, they are able to make decisions that feel right for them. Some may choose to proceed with screening for peace of mind. Others may decide to avoid it, preferring to focus on their current quality of life rather than potential future risks. Both decisions can be valid, as long as they are informed and intentional. This is especially important after 60, when healthcare is no longer just about prevention, but also about preserving independence, comfort, dignity, and the ability to live life on one's own terms. A screening that leads to anxiety, unnecessary procedures, or loss of function may not always support those goals, even if it detects something early. We must also recognize that healthcare systems themselves can sometimes encourage overtesting, often out of habit, structure, or fear of missing something rare. But the absence of a test is not the absence of care. Sometimes, careful observation, regular check-ins, and attention to symptoms can provide more value than a battery of routine screenings. This is where shared decision-making becomes so powerful. It allows space for clinical knowledge and personal preference to meet in the middle. It respects the expertise of the doctor, while equally respecting the lived experience and priorities of the patient. And in that balance, better decisions emerge. It is also worth remembering that medical decisions are not permanent. They can be revisited. What feels unnecessary today may become relevant in the future, and vice versa. This flexibility is important because health itself is not static. It changes over time, and our approach to it must change as well. So rather than seeing screening as a fixed obligation, it should be seen as an ongoing conversation, one that evolves with age, with health status, and with personal values. That perspective removes pressure and replaces it with clarity. Ultimately, the role of the physician is not simply to order tests, but to guide understanding. And the role of the patient is not simply to comply, but to participate. When both sides engage fully, the result is not just better decisions, but more meaningful care. Because in the end, the most powerful tool in medicine is not the machine, not the scan, not the tests. It is the conversation that helps us decide whether any of them are truly needed.